and welcome to Anatomy and Physiology podcasting. So, today we're going to discuss the autonomic nervous system. And before we begin, we'd like to assess just where we are geographically in the nervous system. So, with autonomics, we are discussing the motor side of the nervous system, but this is the involuntary motor, right? So, that's what the autonomics are. They're involuntary motor as opposed to voluntary motor. Voluntary motor is, of course, acetylcholine based, and it controls, it's the nervous system's efferent fibers that control the voluntary skeletal muscle, right? And that's what makes it voluntary motor. So with the autonomic nervous system, it's involuntary and it's not going to innervate skeletal muscle. It's actually going to innervate visceral organs. So things like the heart, the intestines, and even glands such as sudoriferous glands or sweat glands, for example, and other digestive glands, for example. So that's going to be in the command of the autonomic system. You don't consciously think that your heart needs to beat and therefore it beats. No, it beats on its own, for example. You don't consciously relax the smooth muscle of your lungs. That's just done for you, depending on the scenario. So, really, autonomics is involuntary. It's things that are occurring in your body beyond your consciousness and beyond your control, depending on the situation. And we have two branches of the autonomic nervous system. We have the sympathetic branch, the fight or flight, and the parasympathetic branch, the rest and digest. And so we're going to evaluate those in more detail. So on this slide, we're observing the various innervation of the nervous system. And first, let's look at the somatic nervous system. The somatic nervous system is another way of saying the voluntary motor nervous system. So at the very top, the somatic nervous system, this is the one that innervates skeletal muscle. So this is voluntary, it's under conscious control. This is what we've been talking about since AP1. We discussed it in the first neuro section, where you have actual innervation to the muscle, and where the nerve depolarizes, the muscle depolarizes, and then the muscle, it opens up the sodium channels, and then we have the calcium spill out, and the troponin and tropomyosin, and myosin heads binding, and the shortening of the sarcomere. So all of that is what we're discussing there. That's the somatic nervous system. And really what the somatic nervous system does is it releases acetylcholine onto the target muscle. It binds the acetylcholine receptor, which depolarizes the muscle, and then that's when we continue with that process, and the muscle shortens and contracts, right? So it's really simple. We've really discussed how acetylcholine is the neurotransmitter for muscle contractions, for voluntary skeletal muscle contractions. That's all from AP1. We've discussed this with the other pathologies such as myasthenia gravis and Lambert-Eaton and so on and so forth. So this is just a straightforward one. The somatic nervous system, acetylcholine and acetylcholine receptor. But when we look at the involuntary, the autonomic nervous system, the involuntary motor nervous system, which is autonomic, we have the sympathetic branch and the parasympathetic branch. And with something I'd like to establish before we get into various details about that is that the first synapse, the first two neurons that meet, the first synapse of all autonomic neurons, the first synapse always involves acetylcholine. It always involves acetylcholine, whether it's sympathetic or parasympathetic. It involves acetylcholine binding to nicotinic receptors. So the very first synapse there, which is highlighted in yellow, showing you acetylcholine binding, that first synapse is always acetylcholine. And the receptor for acetylcholine on that synapse is always a nicotinic receptor. This is an important time to mention that acetylcholine can bind both nicotinic and muscarinic receptors. Okay? And so nicotinic receptors are always going to exist on the very first synapse of all autonomic neurons. It's going to be nicotinic, and it's going to bind acetylcholine. This is also a relevant time to add that both the adrenal medulla, remember the adrenal medulla, how we had GFRM and we had on the adrenal glands, and I said that the interior of the adrenal gland, the medulla, kind of like the stuffing inside of the adrenal gland, is not really part of the gland. There was an adrenal cortex, and then there was the adrenal medulla itself. And I said that the cortex was like the exterior crust, and that there was like an inside stuffing, kind of like the interior, and that was the medulla. And that medulla was actually not part of the cortex itself. It was completely separate tissue. And I mentioned how that tissue, the adrenal medulla, behaves more like a neuron than it does like a gland. But in a way, it also behaves like a gland because it synthesizes a hormone that's released into the blood. However, the hormone release is really influenced by the nervous system. And so this is kind of where I get to elaborate more on what I meant by that. So the adrenal medulla is actually sort of like a neuron that synthesizes hormones in a strange way. And the hormones that it synthesizes are epinephrine and norepinephrine. And really what transpires here is that the adrenal medulla, and this is relevant, has nicotinic receptors on it. It has nicotinic receptors on it, and acetylcholine binds those nicotinic receptors, which is really always the case, right? Acetylcholine binds either nicotinic or muscarinic. So acetylcholine is released. It binds nicotinic receptors on the adrenal medulla, and that causes the adrenal medulla to release epinephrine and norepinephrine into blood vessels as if it were a gland. So I want to emphasize that because it's a little bit different from what we're going to see in a moment between sympathetic and parasympathetic. Acetylcholine really kind of stimulates the nicotinic receptors on the adrenal medulla to flood the bloodstream with epinephrine and norepinephrine, and that's that adrenaline rush that you feel whenever you have anxiety or before you go on a roller coaster or whatever. That's the adrenaline rush, right? Is that epinephrine, norepinephrine rush. And it's kind of a systemic activation of the fight or flight response. And so we'll get into more detail about that in a moment. Other glands that also have only nicotinic receptors and are stimulated by acetylcholine are sweat glands or sudoriferous glands. So sweat glands are stimulated directly by acetylcholine binding nicotinic receptors on sweat glands. So when you sweat and when you have that adrenaline rush, it's acetylcholine binding nicotinic receptors on sweat glands or on the adrenal medulla, respectively. So that's also really interesting. So now, with that said, let's take a look at sympathetic neurons versus parasympathetic neurons. So sympathetic neurons. For the first synapse in a sympathetic neuron, it's always acetylcholine, that's the neurotransmitter, binding nicotinic receptors. That's true of all synapses here. Then there is a second neuron, which will, when stimulated by the binding of acetylcholine to nicotinic receptors, release its own neurotransmitter. Now, this is an important time to mention since there are two neurons, there's going to be a preganglionic neuron or a presynaptic neuron. Preganglionic or presynaptic mean the same thing. So there's going to be a presynaptic neuron or preganglionic neuron and a postsynaptic or postganglionic neuron. And so it's really essentially a way of saying the first one and the second one, right? Presynaptic versus postsynaptic. And what is the synapse that we're referring to? That first synapse where the two neurons communicate with each other, the one that releases acetylcholine onto nicotinic receptors in all autonomic neurons. So we have a presynaptic and a postsynaptic. The first synapse is going to be acetylcholine on nicotinic receptors. And in the sympathetic nervous system, and this is what's different, in the sympathetic nervous system, the postsynaptic neuron will release norepinephrine, and sometimes epinephrine, but for our purposes, norepinephrine, NE, onto the target organ to deliver the desired effect. And when a sympathetic neuron releases the norepinephrine onto the target organ, it's going to have a fight or flight response on that organ. And I will explain that a little bit later. Then let's move on to the parasympathetic neurons. So the parasympathetic neurons have a presynaptic and a postsynaptic as well. At the synapse, at the first synapse, you have acetylcholine and nicotinic receptors. You always have acetylcholine and nicotinic receptors at the first synapse in all autonomic ganglia. So we have that first synapse, acetylcholine onto nicotinic, but what's different here compared to the parasympathetic is that the postsynaptic neuron, or the postganglionic neuron, is going to release acetylcholine again instead of norepinephrine. Norepinephrine was released by the postsynaptic neuron in sympathetic neurons. Here we're in parasympathetic, so we're releasing acetylcholine again, like we did in the first time. However, that acetylcholine is going to bind muscarinic receptors. Muscarinic, because they react with muscarine, okay, which is another chemical. So, what's relevant here to note is that the first synapse in both sympathetic and parasympathetic autonomic neurons is acetylcholine binding nicotinic receptors. In sympathetic neurons, the postsynaptic neuron is releasing norepinephrine onto the target organ. And in parasympathetic neurons, the postsynaptic neuron is releasing acetylcholine instead of norepinephrine, and that acetylcholine is binding muscarinic receptors instead of nicotinic. Norepinephrine always binds adrenergic receptors. So in order, the sympathetic neuron, the presynaptic neuron, is going to release acetylcholine, which binds nicotinic receptors on the postsynaptic neuron. And that postsynaptic neuron, when stimulated with acetylcholine on its nicotinic receptors, will release norepinephrine onto the target organ. And the norepinephrine will bind adrenergic receptors on the target organ and deliver a fight or flight response. For example, tachycardia on the heart. So if you're running away from a bear, for example, you're going to initiate the fight or flight response. You're going to want to release norepinephrine onto the target organ in the sympathetic response, and that norepinephrine will bind adrenergic receptors, which will stimulate tachycardia in the heart to deliver more blood to the body so that you can run away from the bear that's chasing you, or fight it if you wish. I wouldn't recommend that. Now, with parasympathetic, it's different. This is the rest and digest system. So what's going to happen here is the presynaptic neuron, again, is going to release acetylcholine, and that acetylcholine is going to bind nicotinic receptors on the postsynaptic neuron. Always the first synapse, whether it's sympathetic or parasympathetic, will release acetylcholine, and it will bind nicotinic receptors to stimulate the postsynaptic neuron. And that postsynaptic parasympathetic neuron is going to release acetylcholine here. And that acetylcholine is going to bind muscarinic receptors on the target organ, which will stimulate the rest and digest response. For example, releasing digestive enzymes to digest food that you just consumed. Another classic rest and digest function would be, for example, for the bladder to contract its detrusor muscle and relax its sphincter to allow you to urinate, right? So that's not really something that we would prioritize when we're under threat. That would be something we would prioritize when we are under relaxed conditions, for example, right? When we're under a threat, we really need to get away or fight it. We really need tachycardia. We really need blood flow, the skeletal muscles to contract and get us away, the brain to have a lot of glucose and blood supply, the lungs, for example, to be able to dilate their smooth muscles to allow more air and oxygen in. So the lung, we want to dilate all the bronchioles in the lungs to deliver more oxygen. We want to have tachycardia to deliver more blood and deliver that oxygenated blood to the lungs and body, right, and to the skeletal muscles especially. So you can kind of reason through the response in a scenario base. Is it rest and digest, or is it fight or flight? When are you going to have bradycardia? Rest and digest. When you're going to have tachycardia? Of course, that would be during the fight or flight response, right? And on that note, whenever you do have an alarming situation, you're going to want to depolarize the adrenal medulla. So when you want to activate the fight or flight response systemically, you're not really going to want to wait for each individual sympathetic neuron to activate itself, right? You have an emergency situation. You need to hit the panic button. You need to hit the emergency button. And that's really when the adrenal medulla comes in. So the adrenal medulla kind of acts like a sympathetic neuron in a way, where you have a presynaptic neuron that releases acetylcholine into the adrenal medulla, and that acetylcholine, kind of like a synapse, will bind nicotinic receptors in the adrenal medulla, and those nicotinic receptors will stimulate the adrenal medulla to flood the bloodstream with epinephrine and norepinephrine, and a nickname for those is adrenaline, right? A hormone made by the adrenal medulla. And so it's kind of like hitting the panic button. It's like I'm not going to wait for each and every sympathetic neuron to depolarize in my body individually. I'm just going to flood the bloodstream with epinephrine and norepinephrine, which is the second hormone that's released in sympathetic neurons, and that will activate systemically every sympathetic neuron that receives blood flow, which is all of them, right? It's kind of like hitting the panic button and activating the fight or flight response systemically all at once through the adrenal medulla, instead of waiting to depolarize each sympathetic neuron individually and waiting on that response, right? It's like the panic button. I always tell people it's the panic button. And then at the same time, your body is kind of anticipating, okay, this individual is going to either fight or run away from this threat. So let's go ahead and activate the sudoriferous glands or the sweat glands, and let's go ahead and sweat because we're about to do some heavy duty work. We need to control our temperature. So sweat glands kind of work similarly to the adrenal medulla, where there is a neuron, a sympathetic neuron that goes, a presynaptic sympathetic neuron that goes directly to the sudoriferous glands, the sweat glands, and synapses on them, releases acetylcholine directly on them, which activates the nicotinic receptors on all the sweat glands and kind of activates them all with acetylcholine and nicotinic receptors to sweat, right? And so there isn't really a two-step process. It's just kind of like acetylcholine, nicotinic, sweat. And so what I'm really trying to emphasize here is, the point here is to know which things have which receptors and which neurotransmitters are released where. Nicotinic receptors. Where are the nicotinic receptors? Well, they're on all the synapses in the autonomic nervous system. All of the synapses. So all of the first synapses, that is, right? So the first synapse is always acetylcholine on nicotinic. In sympathetic, acetylcholine on nicotinic. In parasympathetic, acetylcholine on nicotinic for every first synapse. They're also going to have acetylcholine and nicotinic receptors in the adrenal medulla and sweat glands. So every first synapse, the first synapse in sympathetic, the first synapse in parasympathetic, acetylcholine on nicotinic. The adrenal medulla and sweat or sudoriferous glands. That's where the nicotinic receptors are. Where are the adrenergic receptors? Adrenergic goes with the target organ of a sympathetic, right? So in the sympathetic nervous system, it goes acetylcholine on nicotinic receptors in the first synapse and norepinephrine to adrenergic receptors on the second synapse. In parasympathetic, it goes acetylcholine on nicotinic receptors in the first synapse, which is the case for all first synapses in the autonomic nervous system, and then acetylcholine again, but this time on muscarinic receptors on the target organ. Sympathetic, acetylcholine on nicotinic, norepinephrine on adrenergic. Parasympathetic, acetylcholine on nicotinic, like it is for all first synapses, and then acetylcholine on muscarinic. Acetylcholine, nicotinic, norepinephrine, adrenergic, that is the sympathetic nervous system. Acetylcholine, nicotinic, acetylcholine, muscarinic, that is the parasympathetic nervous system. And then just remember in the back of your minds, acetylcholine on nicotinic, adrenal medulla, acetylcholine on nicotinic, sudoriferous or sweat glands. The same way it is for the sympathetic nervous system. And that's how you'll get it down. Knowing these synapses is going to be very important. knowing which neurotransmitter goes with which branch is very important. So you'll want to be able to get that down. It's really straightforward once you kind of organize it in your mind. On that note, I'd like to emphasize, notice how the nicotinic receptors all respond to acetylcholine, and the muscarinic receptors, which are the second synapse in parasympathetic nervous system, notice how that also reacts with acetylcholine. So nicotinic receptors bind and react to acetylcholine, and muscarinic receptors bind and react with acetylcholine. So both muscarinic receptors and nicotinic receptors are known as cholinergic receptors. They react with acetylcholine. Are adrenergic receptors cholinergic? No, they react with norepinephrine. So the cholinergic receptors are nicotinic and muscarinic. They both react with acetylcholine. So let's take a look again at these neurons. The sympathetic neuron has a nicotinic synapse where it reacts with acetylcholine first, and then an adrenergic synapse where it reacts with norepinephrine. In the parasympathetic nervous system, we have a nicotinic synapse which reacts with acetylcholine first, and then we have a muscarinic synapse which also reacts with acetylcholine. So if you'll notice, all of the synapses in the parasympathetic nervous system are cholinergic. The first is nicotinic, the second is muscarinic, but both nicotinic and muscarinic are cholinergic receptors because they react with acetylcholine. The only cholinergic receptor in the sympathetic nervous system is the nicotinic at the first synapse, right? So don't be confused with these terms. You really want to be able to be comfortable with these terms. Cholinergic, nicotinic, muscarinic, right? The umbrella of cholinergic encompasses nicotinic and muscarinic receptors. Nicotinic is first, muscarinic is second in the parasympathetic nervous system. And then you have adrenergic, which is only in the sympathetic and reacts to norepinephrine. So please make sure you keep that down and bear in mind how the synapses go. The first synapse is always nicotinic with acetylcholine. The second synapse depends on which neuron you're talking about. If it's sympathetic, it's norepinephrine on adrenergic. If it's parasympathetic, it's acetylcholine on muscarinic. And then recall that the cholinergic neurons, the cholinergic receptors, are nicotinic and muscarinic. And then we also want to recall that acting like a cholinergic neuron is the adrenal medulla, which has nicotinic receptors that react with acetylcholine, and the sudoriferous sweat glands, which have nicotinic receptors that react with acetylcholine. And because they're nicotinic, they are also technically cholinergic. So keep that in mind. So let's compare and contrast the sympathetic nervous system with the parasympathetic nervous system. We'll note that the sympathetic nervous system has a thoracolumbar distribution. Do you see how all the fibers are located in the thorax and the lumbar region for the sympathetic nervous system? And if you'll notice that the fibers for the parasympathetic are coming from the cranium and the sacrum. So there is a cranial sacral distribution of the parasympathetic nervous system, whereas the sympathetic nervous system has a thoracolumbar distribution, where the fibers are coming out of the thoracic and lumbar regions as opposed to the cranio or sacral regions, right? So with the parasympathetic nervous system, we'll also note that there isn't as much organization. You'll notice that the fibers just kind of go out and then bind to the target organ. With the sympathetic nervous system, there's something called a sympathetic chain ganglia, a chain of ganglia, a chain of synapses that occurs. You'll notice how the fibers in the sympathetic nervous system come out of the spinal cord, go to a ganglia in the middle, and then go out to the target organ. So there is a sympathetic chain ganglia, a sort of network of organization in the sympathetic nervous system, that the parasympathetic really lacks. And it kind of makes sense. If you have a fight or flight response, what's really more serious? What's something you want to be really organized about how you fight or flight, right? That's the difference between survival and death. Parasympathetic rest and digest, not as much organization. It's not really quite as relevant, right? So there really isn't as much organization. I'm not saying it's not relevant. I'm just saying, for survival purposes, it doesn't really require as much organization. So with the sympathetic nervous system, there's a sympathetic chain ganglia, and it's a thoracolumbar distribution, as opposed to less organization and a craniosacral distribution, right? And it makes sense why it's craniosacral. You want to control a lot of glands in the head and the face, and of course, lower down for the digest portion, right? Rest, digest, defecate kind of is really kind of what we go with that. Releasing waste as well as being able to digest what you ingest, right? And another difference is that you have, for the parasympathetic, you'll notice that the first fibers in the parasympathetic are long, and then they get short. So in parasympathetic nervous system, the fibers or the neuron fibers are long and then short for the axons. And in the sympathetic, they're short and then they're long. They're short before the sympathetic chain ganglia, and then after the sympathetic chain ganglia, the fibers are long. So parasympathetic, long, short, sympathetic, short, long. So that's also another difference. So craniosacral distribution versus thoracolumbar. No chain ganglia versus a sympathetic chain ganglia. Not as organized versus organized. Long then short fibers versus short then long fibers. And this is all for parasympathetic and sympathetic respectively, right? And then we want to recall parasympathetic is rest and digest and defecate. Sympathetic is fight or flight. The first fibers in both of them are going to be lightly myelinated, and then the fibers for the postsynaptic neuron are going to be non-myelinated. And that's actually going to be relevant when we discuss the white versus gray communicantes, right? And as far as where the fibers go in the spinal cord. And it kind of makes sense. I mean, the myelinated ones are going to be white. The non-myelinated are going to be gray. It makes sense. Myelin appears white, so whatever myelinated fibers occur are going to be coming out of the white communicantes, right? It really is a straightforward concept. So looking at the parasympathetic nervous system in more detail, we see that craniosacral distribution. In the cranial distribution, we have the nerves or the axons going to various ganglia. Now, they're not organized in a chain ganglia the way the sympathetic nervous system is, but there are still ganglia because there's a synapse, and a ganglia is essentially a synapse, right? So we have the ciliary ganglion, pterygopalatine, submandibular, and otic. And you'll notice that the ciliary ganglion is what's controlling the autonomics to the eye, right? Parasympathetic to the eye. And it makes sense. We have a lacrimal gland there. We want to be able to make tears, stimulate that to make tears. And then you want to be able to stimulate the eye to change its pupil size, right? For example, if we were in the sympathetic nervous system, fight or flight, we would want to dilate the pupil to let more light into the eye so that we could see where we're going, or we could see where we're running away, or we could see better when we're going to fight. So the ciliary ganglion affecting the eye makes sense. For the parasympathetic, you're not really running anywhere. You're probably reading at close distance. You can think of yourself, I guess, reading on the toilet or whatever for the rest, digest, defecate if you wish. You don't really need to dilate the eyes. You don't need to let more light in because you're looking at close distance, right? Or close. You're not at a distance. You're really actually close. So the distance is not really quite far. So you don't need to dilate the pupil. You don't need to let more light in. So you can constrict the pupil, right? And that's the concept between myidrasis and meiosis, right? Myidrasis is dilating the pupil as opposed to meiosis, which is constricting the pupil. And right now we're talking about the ciliary ganglion of the parasympathetic. So we're talking meiosis here. We're talking constricting the pupil. We're not fight or flight here. We're rest, digest, and defecate. And so ciliary ganglion will constrict the pupil, right? Pterygopalatine, submandibular, and otic are going to control the salivary glands. These are going to be all relevant for releasing saliva to do the digest portion of rest, digest, and defecate, right? And then below the otic ganglion, we see this really long nerve fiber that goes to the heart, lungs, liver, stomach, pancreas, the other intestines, and other digestive organs. And that really long nerve fiber is cranial nerve 10. That's the vagus nerve. That's the vagus nerve we've been discussing this whole time, that cranial nerve 10 that controls most of the parasympathetics in the body. So we've discussed it before, and you'll notice that one of its branches is to the heart, and that's the vasovagal response that leads to bradycardia and syncope or fainting, right? When you see something you don't like, you stimulate that vagus nerve, it's parasympathetic, rest and digest. It initiates bradycardia when it depolarizes at the heart. Bradycardia leads to less blood flow to the brain, syncope, and fainting. That's the vasovagal response. It's all parasympathetic. And the vagus nerve is the longest parasympathetic fiber in the body. So we're not surprised to have that response. And then you have the sacral distribution of the parasympathetics. And we'll see, for example, this is kind of best illustrated with the bladder and with the penis, actually. So with the bladder, what is the parasympathetic nervous system going to do? Well, it's going to relax the sphincter to allow you to urinate, and it's going to contract the detrusor muscle of the bladder so that it can expel the urine, right? Contract and remove the urine from the bladder lumen. So that's a function of the parasympathetic. And then we always say with the penis, it's parasympathetic and sympathetic. The penis has to become erect, and then it has to ejaculate. And so the erection is achieved by the parasympathetics point, and the ejaculation is achieved by sympathetics, sympathetic shoot. So we say point shoot for the penis, right? Parasympathetic and then sympathetic, erection and ejaculation respectively. And then with the bladder, we're talking about parasympathetics here, so it would contract the detrusor muscle and relax the sphincter to expel urine. We can kind of infer what it would do with the digestive organs, release digestive enzymes, cause the muscles, the smooth muscle in the intestines to contract, what we call peristalsis, or to move the food through the intestines, right? So rest, digest, and defecate, right? Relevant to note here is that the celiac plexus from the parasympathetic nervous system is supplying a lot of the abdominal organs for that digest and defecate portion of the parasympathetics function. So we've discussed that there are presynaptic neurons in the autonomic nervous system and postsynaptic, right? Before the synapse and after. So naturally, we're going to have the presynaptic leaving the spinal cord or leaving an area, and then the postsynaptic is going to go to the target organ. And so there has to be an interplay there. There has to be a part of it, like a fiber that gives off the presynaptic, and then a fiber that gives off the postsynaptic. And so we also want to recall that the presynaptic is lightly myelinated, and the postsynaptic is non-myelinated. So we have white and gray rami communicantes, one that looks white and one that looks gray. So the question is, which one is going to harbor the presynaptic neuron versus the postsynaptic? The white is going to have the presynaptic myelinated or lightly myelinated, and the gray communicantes is going to have the postsynaptic non-myelinated autonomic neuron. And this is true for sympathetic and parasympathetic. Now, when we look at the sympathetic distribution of the autonomic nervous system, we notice that it's very organized. There is a sympathetic chain ganglia, or the sympathetic trunk. They mean the same thing. You'll notice how the fibers for the sympathetic nervous system come out of the spinal cord into white rami communicantes because they're myelinated, right? The presynaptic neurons are always lightly myelinated, and they go through the white rami communicantes to the sympathetic chain ganglia, and then from the sympathetic chain ganglia, the postsynaptic non-myelinated fibers go out through gray ray communicantes to the target organ, right? And we can kind of infer what function the sympathetic will have. It's fight or flight. It's going to dilate the eye to allow more light in so that we can fight or flight to be able to see. It's going to induce tachycardia. It's going to cause bronchodilation as opposed to bronchoconstriction. We need to get more oxygen and air into the lungs to be able to fight or flight. So it's going to dilate the smooth muscle of the bronchioles. It's going to dilate and increase the diameter of the bronchioles to allow more air in, to allow more oxygen in. Tachycardia, to pump more blood to skeletal muscle in the brain. It's going to inhibit the rest and digest function at the digestive organs, because really our priority right now when we're running away from a bear or we have a threat that's been induced, our priority really isn't to digest steak or our last meal. It's our priority is to get away or face the threat. And so really the priority is going to be dilate the eyes, dilate the airways, induce tachycardia, shunt blood away from the digestive organs, shunt the blood towards the skeletal muscle instead. The skeletal muscle needs it more than the stomach and the intestines. The stomach and the intestines can wait. Parasympathetic can wait. We can rest and digest later. We need to run away from the bear now. We need to see where we're going. We need oxygen for our muscles in the Krebs cycle and electron transport and all of that. We need blood. We need glucose. And so that is going to be the priority. Okay? And so let's take a look at these neurotransmitters in more detail. So acetylcholine binds cholinergic receptors. The cholinergic receptors are nicotinic and muscarinic. The parasympathetic nervous system has both nicotinic and muscarinic. But out of the cholinergic receptors, the sympathetic nervous system only has nicotinic because all first synapses are acetylcholine on nicotinic, right? And the second synapse in the parasympathetic nervous system is acetylcholine on muscarinic, right? So the cholinergic neurons are nicotinic and muscarinic. They bind acetylcholine. And so that is all going to be for the first synapse for nicotinic, right? For all sympathetic neurons. Muscarinic is going to be on all parasympathetic target organs. So muscarinic is exclusively on parasympathetic. And so this is where it gets kind of crazy with the terminology, right? Because parasympathetic organs, right? The parasympathetic innervation on organs is muscarinic cholinergic, right? It reacts with acetylcholine, but it's the muscarinic variety that it reacts with acetylcholine for the parasympathetic target organ, right? So be very careful with this cholinergic, nicotinic, muscarinic, adrenergic. All these terms can be a bit confusing. Now, adrenergic receptors, what do they bind? Adrenergic receptors bind norepinephrine and epinephrine, right? Now remember that norepinephrine and epinephrine can come from a postsynaptic neuron or from the adrenal medulla essentially pushing that panic button, right? Regardless, norepinephrine and epinephrine will bind adrenergic receptors. So recall, muscarinic receptors are cholinergic and they are exclusively for the parasympathetic. Adrenergic bind norepinephrine and epinephrine, and they are exclusively sympathetic. And out of the adrenergic receptors, we have beta 1, beta 2, beta 3, alpha 1, and alpha 2. Beta 1 is predominantly on the heart and kidneys, and a little bit on adipose tissue, but I want you to know heart and kidneys. On the heart, stimulating beta 1 receptors will cause tachycardia. Blocking beta 1 receptors, such as in beta blockers, will cause bradycardia. And that's actually one of the ways we treat heart disease, right? If the heart is overworked because there's heart failure, allow it to relax. Beta blockers, right? The beta 1 receptor typically causes tachycardia. If you block it, you get bradycardia, right? That's why we call them beta blockers. They block beta 1 adrenergic sympathetic neurons, right? Or receptors, rather. So beta 1 causes tachycardia when stimulated, bradycardia when inhibited or blocked, and it also stimulates the kidneys to release renin. And we recall renin is part of RAS, and from the endocrine section, renin-angiotensin-aldosterone system, and aldosterone causes sodium and water retention, which causes hypertension, right? So beta blockers are really wonderful because not only do they block the beta 1 receptor causing bradycardia instead of tachycardia, because now it's blocked, they also stop the kidney from releasing renin, which would cause hypertension as well and overwhelm the heart. So overwhelm the heart with that afterload, remember? So it's really kind of a remarkable process where beta blockers block the tachycardia and the renin release of the sympathetic nervous system. But under normal conditions, stimulating the beta 1 adrenergic receptor in the sympathetic nervous system causes tachycardia and renin release. Then we have the beta 2 receptor, which is mostly in the lungs. And the beta 2 receptor actually dilates the bronchioles, right? So it actually causes smooth muscle relaxation in the lung to dilate the bronchioles and allow more air into the lung. And that makes sense. That's something the nervous system, the sympathetic nervous system, is really going to want to do in a fight or flight response. So the lungs will dilate their bronchioles and allow more air in. And we actually take advantage of this to treat asthma. So Ventolin or albuterol, those inhalers for asthma, what they're essentially doing is they're stimulating the beta 2 adrenergic receptors of the lung to dilate the bronchioles and treat the asthma. Because what is asthma? It's an allergic-like constriction of the bronchioles, causing airway hypersensitivity and bronchoconstriction. So how do you treat the bronchoconstriction of asthma? You cause bronchodilation. What causes bronchodilation? Stimulating the beta 2 adrenergic receptors of the sympathetic nervous system in the lung, right? You just kind of mimic the fight or flight response in exclusively the lung to cause the lungs to dilate. You tell the lungs, hey, here's a sympathetic response. You should dilate, And that's something the lungs will naturally do when they're stimulated by their beta 2 adrenergic receptors. And so that's really what albuterol or Ventolin will do, those inhalers. They're causing bronchodilation, a fight or flight response or a sympathetic response in the lung, which causes bronchodilation to overcome the bronchoconstriction of asthma, which is the disease state of asthma itself, right? Beta 3 is rather straightforward. It's on adipose tissue. It causes lipolysis, so it causes the fat cells to release their lipids. It would be great if we could really take advantage of this for weight loss, But of course, you'd have to metabolize those lipids to be able to be effective, right? And then we have alpha 1. So that's really on blood vessels. And what alpha 1 will do is it'll constrict blood vessels and cause hypertension. So really blocking alpha 1 is in our best interest. But when you're kind of running away and everything, you want to maintain a good tension in your blood vessels so that you ensure that blood is getting around. And so sometimes alpha 1 can be relevant for that, right? Maintaining tone in your blood vessels. But we're really more interested in blocking it more often than not to kind of ease the hypertension. And then you have alpha 2, which inhibits insulin secretion and stuff. I'm not really as concerned. The ones that I want to emphasize are beta 1 on the heart and kidney, beta 2 on the lungs, and alpha 1 on the blood vessels. Those are the most relevant to know. So let's take a look at some of these agents that stimulate the autonomic nervous system. So nicotinic agents, no surprise, nicotine, right? Stimulates all nicotinic receptors in the body, including sweat glands, right? Including the sympathetic fight or flight response. So really, nicotine is not all that great, right? It's kind of constantly stimulating the nicotinic receptors, causing a constant like fight or flight response, which can add a lot of stress on the body, and that's kind of why it causes the hypertension and a lot of the heart and cardiovascular pathologies. Aside from the fact that it's also coming in with cigarettes and other toxins and so on, right? Even nicotine itself really can be problematic. Then we have these parasympathomimetic agents. So they're muscarinic agents that stimulate the parasympathetic nervous system. That's what parasympathomimetic means, right? They're muscarinic agents. Um, and so these are going to activate the parasympathetic nervous system. You need to know pilocarpine and bethanechol. So pilocarpine is a glaucoma agent, right? It treats glaucoma. It opens the aqueous humor and allows drainage, right? Which kind of makes sense. If you think about it, in your eye, you want to be able to drain away the fluid in your eye to prevent glaucoma. Because what is glaucoma? It's just ocular hypertension or hypertension because of too much fluid in the eye. So what do you need to do? You need to be able to drain the eye. Well, in order to drain the eye needs to be relaxed. So the pupil cannot be dilated. It needs to be constricted or relaxed or let go so that there's no tension in it. So that's what meiosis is, relaxing the eye, constricting the pupil. And what's going to constrict the pupil? The parasympathetic nervous system, because you don't need the pupil dilated to let more light into the eye. Parasympathetic is rest and digest. You're resting. So you can afford to relax the eye when you're relaxed or resting and digesting, right? So you would use a parasympathetomimetic agent or a muscarinic agent, pilocarpine, to relax the pupil, relax the eye, and allow it to drain and treat the glaucoma. So pilocarpine is an example of a muscarinic agent. And then sometimes the elderly, especially those that take, for example, anticholinergics. Benadryl, for example, has anticholinergic effects. So, what is a cholinergic neuron? Well, those are very prominent in the parasympathetic nervous system, rest and digest, right? And so, if you take an anticholinergic, you're essentially taking an anti-parasympathetic or an anti-rest and digest. And that's why a lot of times the elderly can get urinary retention and retention of feces and urine and everything, especially urine, when they take anticholinergic agents, which Benadryl is an anticholinergic agent, for example, right? And it's not only an antihistamine, it's also anticholinergic. And that's kind of an issue. Elderly will take a Benadryl for allergies or whatever, and then before you know it, they have urinary retention. They're unable to urinate. Or there is just difficulty urinating, especially in people with, elderly men with benign prostatic hyperplasia or BPH. Whatever the case may be, there's an issue. There's a difficulty urinating, and urinating is in the realm of rest, digest, and defecate. So it's the parasympathetic realm. So what would you give to treat an issue with the parasympathetic nervous system? You would stimulate the parasympathetic nervous system further. So bethanechol is used for urinary retention and difficulty urinating, right? It's a muscarinic agent that kind of stimulates the parasympathetic. Parasympathetic, again, is synonymous with rest, digest, and defecate, right? And our next category are the acetylcholinesterase inhibitors. We've talked about acetylcholinesterase and how it's the enzyme that breaks down acetylcholine. If we inhibit the enzyme that inhibits acetylcholine, we stimulate acetylcholine, right? So if we block acetylcholinesterase, we block the inhibition of acetylcholine. So it's kind of a way of turning acetylcholine on. So acetylcholinesterase inhibitors, we discussed, those treat myasthenia gravis. They increase the availability of acetylcholine by preventing acetylcholinesterase from breaking down acetylcholine, right? So that is neostigmine and the stigmines in general. There's neostigmine, physostigmine, so on and so forth. So the stigmines, neostigmine especially, are used to treat myasthenia gravis. They increase the availability of acetylcholine by inhibiting acetylcholinesterase. Sarin is also something that does this. It's an acetylcholinesterase inhibitor, but it's really used in insecticides, and it's a chemical warfare agent. So you can kind of think of neostigmine as the diluted, mild form of sarin, the part that the version of it that will treat a pathology as opposed to initiate death, right, of an insect or a human or in warfare. Any poison like sarin, diluted enough, like neostigmine, can become a medication, right? And that's really quite remarkable. A medication for a specific pathology, of course, right? And in our case, we're talking myasthenia gravis. And then we have sympathomimetic agents, or agents that stimulate the sympathetic nervous system, specifically the adrenergic receptors of the sympathetic nervous system. The adrenergic, the ones that bind norepinephrine. And examples of that are albuterol or Ventolin. These are going to stimulate the beta-2 receptors on the lung to treat asthma, for example. And then we have phenylephrine, which is the active agent in Sudafed, right? That's going to treat colds, nasal congestion. It's going to be a nasal decongestant. And it's going to bind to and stimulate the alpha-1 adrenergic receptors. And it makes sense, right? When you have a cold, you have congestion. What's congestion? Fluid in the sinuses, fluid in the nasal cavity. Where is the fluid coming from? Blood vessels. How are the blood vessels releasing fluid? They're dilated, right? There's a cold, there's an allergy, there's something going on. The nose is dilating all of its blood vessels, releasing a lot of that blood plasma as water in the sinuses and nasal cavity and causing nasal and sinus congestion. So how do we decongest that? How do we block that process? Well, if dilated arteries are releasing plasma and causing the congestion, the fluid buildup, the rhinorrhea, or the drainage of the nose, the runny nose, and all that, if that's secondary to dilated blood vessels, then we would constrict them to cause decongestion, right? Constrict them, prevent the fluid from coming out, prevent them from congesting the sinuses and nasal cavity. Well, how do we constrict blood vessels? We stimulate the alpha-1 receptors on them. The alpha-1 adrenergic sympathetic receptors. Stimulate them. And you would stimulate them with the agent phenylephrine, which is in Sudafed, right? It's a sympathomimetic agent, an agent that mimics sympathetic activity, right? And then we have sympatholytic agents, or agents that cut off or block sympathetic activity, right? So a sympatholytic agent, for example, would be a beta blocker like propranolol. All the alls, like metoprolol, propranolol, those are referring to beta blockers. So beta blockers are specifically beta-1 blockers. They're beta-1 adrenergic receptor sympathetic blockers, or sympatholytic agents. Agents that block or inhibit the sympathetic nervous system. Classic ones are beta blockers, given to induce bradycardia, or aka block the tachycardia caused by the sympathetic nervous system, which effectively is bradycardia, right? Slow the heart rate down. Give the heart a break. Slow the heart rate down. Induce bradycardia by blocking the sympathetic response at the heart, blocking the beta-1 adrenergic receptors of the heart. That's how we're going to treat the hypertension, the heart disease. The heart is overworked in heart disease. We need to calm it down. Calm it down by blocking the beta-1 adrenergic sympathetic receptors in the heart. That will cause bradycardia because you've blocked the sympathetic. Now the parasympathetic takes over, right? So that is a sympatholytic agent. Propranolol, metoprolol, all the alls, the beta blockers. And then beta blockers also have the effect or the added benefit of also blocking renin release of the kidneys, right? Because those also have beta-1 receptors. So remember, in this chapter, you're always going to want to think of the context in which you have which system taking advantage, right? In the sympathetic response, it's fight or flight. You're going to dilate the eye. You're going to induce tachycardia. You're going to dilate the bronchioles to allow more air and oxygen into the lungs. And you're going to shunt blood away from the digestive organs to the skeletal muscle so that you can run or fight. And then with the rest and digest system, you're going to prioritize glands, glandular secretions, digestion, peristalsis or contraction of the intestines and the stomach to digest and move food through the system, contraction of the detrusor muscle of the bladder, and relaxation of sphincters to allow things through and to allow urine out. You know, relaxation of the anal sphincter to allow feces out, contraction of the smooth muscle of the intestines to move food through and out, and towards the anus and out. So you kind of always want to think of the context of what you're discussing, and then with the eye, you're going to dilate or myodrasis the eye in the sympathetic response, and you're going to constrict or meiosis the eye in the parasympathetic response. And meiosis, especially in the parasympathetic response, is what's going to allow the eye to drain its excess fluid and treat ocular hypertension, which is glaucoma. And that was the effect of the parasympathetomimetic agent, right? The muscarinic agent, pilocarpine, that we discussed earlier. So you want to be able to keep those in line in your mind. And on my last note here, I'd like you to appreciate how the presynaptic autonomic neurons are going through the white rami communicantes, and then after the synapse, the postsynaptic neurons are exiting through gray rami communicantes. The presynaptic fiber is always myelinated and goes into white rami communicantes, and the postsynaptic fiber is non-myelinated and it goes through the gray rami communicantes. Of course it looks gray. It's not myelinated. Myelin is white. So the presynaptic myelinated neuron is going to go through the white rami communicantes. And then you want to remember it's long and short fibers for parasympathetic versus short and then long fibers in sympathetic, right? And those various comparisons and contrasts models, and points that we mentioned in the very early part of this lecture, right? I recommend knowing the differences between the agents, right? The differences between the neurotransmitters and the receptors they bind to. For example, the first synapse is always nicotinic, binding acetylcholine in all the autonomics, sympathetic, parasympathetic, adrenal, medulla, and pseudoriferous glands. And really what changes is what happens afterwards, right? So the first synapse is always nicotinic, binding acetylcholine. It's really the second synapse on the target organ to give you the desired effect you're seeking that's different. That's what uses something different. In sympathetic, it's going to be norepinephrine binding adrenergic receptors, of which there are 5: alpha 1, alpha 2, beta 1, beta 2, beta 3. And those are binding norepinephrine, epinephrine. They're adrenergic. They're part of the sympathetic nervous system. And then for the parasympathetic nervous system, right, the first synapse is, again, acetylcholine on nicotinic, as it always is. And then the synapse on the target organ is going to involve acetylcholine again, but on muscarinic receptors. And muscarinic is exclusively parasympathetic, right? So muscarinic versus adrenergic. And then we want to recall nicotinic synapses are binding acetylcholine, therefore they're cholinergic, and muscarinic receptors in the parasympathetic nervous system exclusively are also binding acetylcholine on the target organ, so they are also, therefore, cholinergic. So have kind of an idea of the response, an idea of what medications will initiate or block that response to treat the pathologies that were mentioned, and be certain to know the neurotransmitter and the receptor for each, and compare and contrast the two systems: sympathetic for fight or flight and parasympathetic for rest and digest.